Hey YouTube, this is Mr. Smiley Florida here, and here's my surgeon, the great guy I keep talking about and going on and on, Dr. Domkowski. So he's going to answer those questions that a lot of you guys sent me, and here he is. Say hi, Doc.
Hello, hi Ken.
This is Dr. Domkowski. He's out of Sebastian, Florida. You went to Duke University, right?
I trained at Duke for several years.
Okay.
Did my medical school up at Georgetown in D.C.
Okay. So he's one of the best, guys. All right.
That's nice of you, Ken.
So one of the questions that I received was basically asking the difference between the vertical sleeve and the lap band, since you do both. Mm-hmm. Can you go ahead and give my viewers a description of both procedures?
Sure, absolutely. The band, I have a little model here that might help, which I'm sure is also easily viewed online. The band is a restrictive procedure. Both are done laparoscopically through 5 small incisions. And the band fits around the top portion of the stomach so that it creates a restriction. So your new stomach is about the size of about 4 ounces. So you eat a small amount of food and you start to feel that restriction from the band and you become full. The surgery is fairly straightforward. There's no cutting, there's no rerouting as there is in the bypass. And this band is connected to some tubing which is attached to the port, which is implanted in your anterior abdominal wall. The important component to the band is the aftercare, meaning you have to get adjustments to your band, especially in the first year and a half after you have it placed. And these adjustments are insertion of some saline through a small Huber needle into your port, and some saline is infused about once a month into this area here, and that increases your restriction. So as you lose weight, you will lose some of this restriction and you will require another adjustment, and some more saline will have to be added. So that's the important thing about the band, is the aftercare. The adjustments are critical. Now, now compare that to the vertical sleeve gastrectomy, also done laparoscopically, where basically I'll remove the band. 80% of your stomach is removed laparoscopically. So your stomach now looks like a long tube, or the sleeve on your shirt. That's why it's called a sleeve.
Gotcha.
It almost looks like, after it's done, just a tube that's the same as your esophagus and your duodenum, which is the first part of your small intestine. Now this doesn't require any adjustments. You don't need to have saline added to any port, because there is no foreign body associated with this surgery. It's restrictive as well, but in a different sense. And unlike the bypass, where there's rerouting of the intestines, the normal flow of food is maintained. So food continues to go through your GI tract just as it is now. That's the beauty of the sleeve. The other nice thing about the sleeve, as I'm sure you and your viewers know, is the ghrelin is removed. Ghrelin is one of the major hunger hormones located in this part of the stomach. That is removed with the sleeve gastrectomy. So now it just becomes a long tube, capacity of about 3 to 4 ounces of food.
Gotcha.
Now I say one shoe doesn't fit everybody. One size doesn't fit everyone.
Right.
So some folks prefer the band because dividing and removing part of their stomach is something that isn't appealing to them.
Right.
And they're okay with a foreign body, and they're okay with the doctor visits to get the adjustments.
Right.
Other people say, I don't want a foreign body in me, I don't want to be seeing you every month, I like you but I don't like you that much.
Right.
So, they don't want to come in as frequently. And so that is some of the reasons people choose different operations. Sometimes your insurance company only covers one type of surgery, and therefore that's the surgery you have to get. They both work well. There are certain situations where I will see people that have, say, a particular BMI or other comorbidities, and they might do better with a band or a sleeve.
Okay. Is there a certain BMI number that you would say, okay, this person should definitely get the sleeve over the lap band?
Right. Not necessarily. It's not hard and fast.
Okay.
You really have to individualize care You have to fit it with the personality of the patient, with what their desires are, with what their comorbidities are, and what their goals are long term.
Okay.
You know, I have seen some people that have been able to, I've seen some people get bands done in other countries that initially had some success and had some trouble for one reason or another.
Right.
And then they went on to a different surgery. So one of the advantages of the band for some of those folks is if they didn't have as much success with the band as they had hoped, they could still get something else done.
Okay.
There are no bridges burned. Whereas other people, right off the bat, they don't want the band. They may have a high BMI, they may be a diabetic, they may have bad obstructive sleep apnea, and they want to go straight to a sleeve.
Gotcha.
And that's fine, and that works really well for them.
Now, another question I got was the actual surgery for the VSG, the vertical sleeve, and it was something called a buoy.
The bougie. The
bougie, and that's
Correct.
basically what you use to size the stomach. Can you
That's
explain
correct.
that as far as how that works?
Absolutely. During the surgery, there is a solid tube that the anesthesiologist puts down your esophagus, and it goes along the lesser curvature of the stomach. The stomach has two parts, or has many parts, but this is the greater curvature, and this is the lesser curvature. The bougie goes along the lesser curvature, and the bougie is used as a guide to create your sleeve, so that the stomach is divided along the length of the bougie. Now, bougies come in different sizes. Sometimes you'll see anywhere from a 48, you'll hear people throw around these numbers, 48, 42, 40, 38, 36, 32.
Mm-hmm.
Those are the different diameters of the bougie sizes. When sleeves were just being done about 8 years ago, they used to use a 50 bougie.
Gotcha.
And some surgeons in the United States, and especially in South America, will use a 32 bougie.
Okay.
That's very narrow. I have found great success with a 40 bougie.
Okay.
I've had patients lose 180 pounds in some instances with a 40 bougie.
Okay.
The difference in diameter between a 40 bougie and say a 36 or 32 is really only a millimeter or two. It's
Okay.
very small. If you want to put it in practical terms, what does a 40 bougie look like? Let me think. If you go to the supermarket and buy a carrot, you know what I mean, a long carrot, not one of the mini ones, that's about the diameter of a 40 bougie.
Okay.
Kind of towards the middle of the carrot.
Gotcha.
It's very narrow.
Okay.
And it stays that way.
Okay.
One of the things we haven't seen a lot with the sleeve is the stretching, as they do with the bypass pouches.
Yes.
Because the sleeve, you're still regulated by your pyloric valve, so the sleeve empties. The stomach empties just like it would normally because of this valve. It doesn't empty by gravity as it does with the bypass.
Gotcha. And another question is pre-op and post-op, specifically post-op. What type of lifestyle changes do vertical sleeve and some lap band, but mainly vertical sleeve, because that's what I'm having. What should they expect as far as, you know, consumption-wise for the first couple of weeks after surgery?
Right.
How is their life going to change? What do you expect?
Right, that's a good question and one we frequently go over. Right after the surgery, you will have a diet booklet, which I call your Bible for a month. And that is a slow diet progression from clear liquids up through very soft food. You'll go to protein shakes, eventually mush, and then soft food. At 1 month out is when you can start to eat what I call real food. By real food, I mean food you need teeth for, you have to chew. In the first couple weeks after the surgery, you're going to be really just sipping on water, your protein shakes, and other liquids slowly through the day. In the first week after surgery, you may not get down those 60 to 80 grams of protein a day in your protein shake. You just simply won't be able to do it. You'll be full after sipping on, say, half a shake over a couple-hour period, and that's okay. Don't panic. When you get a little further out, you will be able to get your required 60 to 80 grams a day of protein, but initially you won't be able to. And then long term, you're really going to fill up. on a small amount of food. If you talk to folks that are 6 months, a year, 2 years out from the sleeve, and they go out and eat, and they go to have dinner, they're having a small piece of fish, some veggies, and they're pretty much done. It's about 4 ounces of food at most.
Wow.
They really fill up quite dramatically, and that's what I stress to my patients is your relationship with food changes dramatically. And as long as you listen to your body and stop when you're full, you'll be fine.
Okay.
Your desire to eat will also be significantly diminished. So, when I say to people, well, you won't want to eat more, and they don't completely relate because they haven't had the surgery yet, afterwards they do because their desire is gone.
Okay. Wow. That's a lot of information.
It's a lot.
So, what would you tell newbies, that are out there that are looking into weight loss surgery? What would you say to them as far as when they're doing their research? How should they go about the process?
Well, take your time. Do due diligence. Go to the seminars. Go to more than one seminar. Ask a lot of questions. You want a surgeon that is obviously well trained in it, that has a lot of experience doing the surgery, and also a staff that's accessible. And talk to other patients. I think that's the most important thing for someone looking to have the surgery done. There's lots of actually very good bariatric surgeons out there, and they just have to do the research and see if that office will allow you to talk to other patients. We have a free monthly support group that I do not attend, that I encourage patients that are going to have the surgery to go to talk to other patients that have had the surgery to get their opinion. It's one thing to hear it from me.
Right.
It's entirely different to hear it from people that have had the surgery. And that's what I mean is to do your research, talk to people that have had it, by the surgeon you're thinking about getting it done with.
All right.
Okay.
Thanks, Doc.
Absolutely, Ken.
All right, and anybody in Orlando, Central Florida area, this is the doctor here. He's down in Sebastian. That's right below, an hour away from Orlando. So if you're in South Florida also, it's about an hour and a half from South Florida. So if you guys are interested, just email me and I'll send you all his information. All right, and once again, thank you, doctor.
Thank you. Appreciate it, Ken.